Hi, welcome to You and Your Health. I'm your host, Dr. David Bertone. It's been almost a year since we had a show here, and we're going to introduce some new topics this upcoming season in all different phases of health-related issues. Today we're going to talk about spring and summer recreational injuries and what you can do in terms of prevention strategies and some of the immediate things you can do if an injury occurs. Our guest today is Dr. Jeffrey Van Gelderan. Dr. Van Gelderan is an orthopedic surgeon and fellowship trained sports medicine physician. His practice, Orthopedic Sports Medicine and Rehabilitation Center in Middletown and Morganville. Dr. Van Gelderan, welcome to the show.
Thank you very much for having me. It's a pleasure to be here.
I appreciate it. Tell the audience a little bit about your background and what your specialty is in terms of your training.
Sure. I grew up locally in Homedale and went to high school in the area. Spent undergrad years at Georgetown and did my residency at NYU. I was fortunate enough to move back to the area after completing a one-year fellowship at UCLA, and I specialize in mostly arthroscopic shoulder, hip, and knee surgery. So rotator cuff repairs, ACL reconstructions. That's basically my specialty.
Excellent. So, we know the common recreational athlete is getting ready to enjoy the spring sports, right? We've all been cooped up for the winter this year. And what are some of the common things that you would see in the office in terms of, typical injuries that people will come in with at this time of the year?
Sure. I think what's becoming more and more popular, obviously, with the change in weather is getting outside and enjoying a basketball game, maybe rolling that ankle the wrong way. Ankle sprains are extremely common, and obviously it's important to know, when to seek treatment. The kids are getting busier with the baseball season, so it's not uncommon to see elbow and shoulder injuries, mostly related to overuse this time of year. But those are a couple of the big ones.
Great. Now, in terms of an ankle sprain, that's definitely a high volume thing. People will typically apply some ice, elevate it, reduce the swelling. When is a good time to really seek medical advice, and what are some of the options when it does occur?
I think that's a very important question. I think there are a lot of people out there that are probably doing a little bit self-diagnosis, and that's obviously good when you have good information. Unfortunately, there is a lot of bad information out there. I think what's important to realize is when it's comfortable enough to bear weight, when you're having a problem getting around, persistent swelling for greater than 5 to 7 days, any sort of mechanical symptoms like clicking. These things are concerning, and if people are having a hard time even walking around on it, that's probably a good time to have it looked at, maybe get an x-ray, make sure there's not a small fracture or a crack that may be missed initially. That all makes pretty good sense.
Now, we see that in physical therapy, we see a lot of ankle sprains, and people think that once you sprain your ankle, you're good to go. Can you talk briefly briefly about some of the, post-injury, and you usually get immobilized a little bit, but people that roll their ankle tend to roll it again unless you retrain it. Is that correct?
That's absolutely correct. And I think there are a few things to work on that are very important. As you said, primarily the issue is probably not going back too soon. When you sprain your ankle, it does involve tearing of ligaments, particularly two ligaments around the ankle. And when those are injured, going back to things too quickly definitely puts you at risk for further damage. I think what's extremely important is to begin, a dedicated program, preferably focusing on, proprioception or balance board type training. Your local therapist obviously can help with that. That's, a great treatment, and that definitely will get you back to things a little quicker. But as you were inferring there, it's really a 4 to 6 week injury a lot of times, sometimes even longer.
Good, good. Yeah, I think it's critical that people recover properly so it doesn't happen again.
Agreed.
You mentioned some of the youth sports leagues, and baseball's popular this time of the year. So what are some of the things that the kids will sustain that you see in the office?
I think most commonly what we see in the office is probably what's referred to as Little League elbow and Little League shoulder. Those are really two overuse injuries, but oftentimes go either underdiagnosed or undiagnosed. And what it is really is an inflammation of the growth plate, usually on the inside of the elbow or around the top of the shoulder. And a lot of times parents will, or children themselves obviously, will overlook it in an effort to kind of make it through the next several games. But, it can be a relatively serious condition where if people continue to throw at those types of velocity, they are at risk for a growth plate fracture. And that's not something that's easy to recover from and could be a season-ending injury.
Mm-hmm. What's some of the things that parents should look for in terms of those injuries, or some of the prevention strategies?
Sure, and I think what's key there, especially in these youth leagues, as you're referring to, is really, like anything, keeping a good journal of pitch counts, specifically what types of pitches the individual is throwing and how many of them on a weekly basis. Obviously, a better rotation of players and not overdoing it is extremely important. Icing after the games is something we did commonly at UCLA and definitely shouldn't be, underemphasized. A very good prevention strategy obviously would involve some sort of, functional training, whether it's core strengthening, kind of building up the rest of the supporting muscles around the throwing athlete is, very important.
One of the things that I've developed is warm-up programs, some specific videos and stretches and cool-down videos for these players, because we know that they're not warming up properly, and then when they're done with their game, they run into the snack bar, and you got to get that tissue to really calm down a little bit.
That's exactly right. In my experience, these kids are oftentimes on 2 or 3 teams, and not uncommon to hear him going from one game to a doubleheader for the next team, and all of this really tends to put a tremendous amount of stress across those joints. So, agreed, a good warm-up and cool-down programs really can't be emphasized enough.
Great. So now we're talking about baseball. Let's move to the next subject, which is softball and the more older patient, really the weekend warrior.
Sure.
What do you see there in terms of those guys?
You know, those injuries unfortunately can be a little more devastating. You know, as the weekend warrior, as you referred to it, is definitely at risk for, say, you know, Achilles tendon ruptures, not uncommon, and again, something that definitely can be avoided or at least minimized with some warm-up techniques. Stretching cannot be, you know, overemphasized there, and ankle injuries as well, and usually more, again, kind of overuse injuries, rotator cuff, you know, tendinitis, not uncommon, especially with throwing sports, as we all put a little more wear and tear on our bodies. We can see these things happen.
So say the softball player is starting to have a little bit of a shoulder ache. What would you typically do for somebody like that, either when they come to the office, and how would you work somebody up with that problem?
Sure. So I think what's important first is obviously, you know, to get a good history from the person, find out when it hurts, during what time of the day, is it specifically with throwing, what phases of the throwing cycle are painful, are they having night pain? These are all important questions. Then we obviously would obtain an x-ray, make sure that there's not any sort of bony problem there, and assuming the diagnosis is one of tendinitis or something, you know, not immediately surgical, then that can definitely be treated with anti-inflammatories, physical therapy, again, to kind of build up the supporting musculature around the area. And if that fails, a cortisone shot is something that we do in the office, and definitely tends to get people going in the right direction a little quicker.
I think there's some bad information about the benefits of cortisone for these types of injuries, and patients get a little nervous when they hear, well, I'm going to get a shot, is it good for me? Can you just explain what the benefits are, maybe what some of the risks are for getting a shoulder injection, say?
I think that's a very good point. I was dealing with such a question this morning, and oftentimes people think that a cortisone shot will really do nothing besides kind of numb their pain, and they're set up for future injury, and that's definitely something that's important to address. I would say that assuming that the problem is really one more of inflammation and some tendinitis, cortisone can actually be curative of that problem. So people that maybe come in and have one shot, that may be, you know, the last intervention they need. They can avoid MRIs, surgery, and it may be curative. Obviously, anytime we're putting a needle in or around the joint, there's always a small risk of infection, probably on the order of 1 in 10,000. And in terms of our diabetic patients, we have to be very careful. It can cause hyperglycemia or fluctuations in blood glucose. So I always counsel people as to, those two things in particular.
Okay. Yeah, I mean, I think there's a huge benefit for the shoulder patient, and I see them in my office, and sometimes we just can't rehab them without reducing that pain. And once you get that pain reduced, then you can really work on retraining the muscle so it doesn't happen again.
Agreed.
Right. So what's happening in terms of the tendonitis? What is some of the mechanism that's occurring there?
Right. So from basically a biological standpoint, you can think of the shoulder or a lot of these joints as having what's called the bursa, which is a sac of fluid kind of over the rotator cuff. It extends down almost to the level of the elbow. So not uncommon for people with rotator cuff issues to actually have pain down the side of their arm, oftentimes related to some inflammation of that bursa or a bursitis.
Mm-hmm.
And as you were alluding to, that can be extremely painful, and if not treated and dealt with somewhat efficiently, can definitely lead to a frozen shoulder or some stiffness and loss of motion,
Mm-hmm.
which is a stiffening of the capsule. So all of these things can be interrelated, and I think it's important for people to understand if treated and recognized early enough, you could potentially avoid, some very annoying consequences down the road.
I think it's a great point, because when I see the patient that's the typical frozen shoulder patient, the stiff shoulder, first of all, it's typically women, because they're
Right.
too busy to really go to the physician and get an evaluation, because they're taking care of everybody else, and they just kind of stop using their arm, and it gets really stiff. So early treatment and early diagnosis is critical. And then most commonly, early motion is critical, and people think it's better to just not move it,
Right.
and then that causes some problems down the line.
So a very good point. And what I oftentimes see is people, or if they're not getting the proper therapy, a lot of times there'll be a lot of isometric work or band work way before people can even get above 90 degrees. And that, unfortunately, you're missing the forest from the trees there, and definitely, again, can just lead to progressive stiffness. So all the, more to get a correct diagnosis.
Great. You mentioned the Achilles tendon rupture. Let's talk about that. I mean, that's another common thing, right? Men in their 40s typically, right?
Absolutely. Yep.
What are some of the risk factors or the reasons why this occurs, and then the subsequent treatment options for that?
Sure. So that's a good point. I think any history of Achilles tendonitis or maybe some soreness in the calf that goes either underdiagnosed or undiagnosed for years can be a precursor. That weekend warrior, as you're referring to, that maybe doesn't have the same supporting leg musculature, is definitely at risk. And when it does happen, it is a real injury there. And the concern, especially with people that are, in my opinion, somewhat younger, in their 40s, the risk is always re-rupture. And the concern there with surgery, to fix the tendon, we can minimize that to about 5%, I would say, as opposed to treating people with casting, which is a completely valid treatment option. The risk there would be the risk of re-rupture, which approaches 15 to 20%. So the advantage of having it fixed is avoiding the possibility of a re-rupture. But obviously, surgery is something we never take lightly. There are its own risks, such as infection or bleeding, probably less than about 1%. But obviously, we always give people the option.
So it's better to fix it, but it can do well with just immobilizing it, either in a cast, right?
Correct.
But there's an increased risk that it might tear if you don't fix it correctly. Now, what happens if you do fix it? What is the typical recovery for something like that?
Yeah, the rehab, either operatively or non-operatively, is involved. With operative repair, people are in a splint for about 2 weeks, and then the advantage of fixing it is we can get it moving relatively quickly. They are in a walking boot, not putting much weight on it for about 4 to 6 weeks. And then we try to have people putting full weight on it at about 6 weeks. And it really would be no impact activity, jogging or running, probably for about 3 to 4 months. So it's not anything to be taken lightly.
Yeah. In terms of the prevention for something like Achilles tendonitis or rotator cuff tendonitis, these general itises or potential tears, what are some of the things that people can do now to prevent it from happening during the season?
Sure. I think, obviously a somewhat regular 2 or 3 times a week, low weight training regimen can be very helpful. Building up the muscles, say, around the Achilles tendon, such as, knee flexors, knee extensors, those types of things, maintaining, basic mobility around these joints, and just, trying to maintain some level of activity so that if you are going out, once every 2 or 3 months, you at least have some sort of preventive strategy.
Yeah, and I think that it tends to be the problem with the weekend warrior. They just go out and they're ready to go instead of some pre-season conditioning and training, which should be done right now.
Agreed.
To get them ready. Great. All right, so we heard about some of the common injuries, and when we come back, we're going to talk in more detail about some other injuries that can occur for spring and summer recreational athletes.
Hi, dear. Take your medicine? Oh, gosh, I forgot. Her nurse. Your claim number? Her personal assistant. Let me just grab a... Her housekeeper. Her cook. Her accountant. When I started taking care of Mom, I didn't realize the challenge of playing so many roles. But above all, I'm still her daughter.
Visit aarp.org/caregiving to connect with experts and other caregivers. Together, we can better care for ourselves and the ones we love.
Hi, welcome back to You and Your Health. I'm your host, Dr. David Bertone. Today we're talking about spring and summer recreational injuries, and our guest is Dr. Jeff Van Gelderan, who's an orthopedic surgeon and fellowship-trained sports medicine physician locally here in Middletown and Morganville. Dr. Van Gelderan, welcome back.
Thank you very much.
So we talked about some of the common recreational injuries. I think it's important to touch on some of the knee injuries that can occur, in particular some of the cartilage or meniscal injuries. What are some of the you see in your office in regard to knee pain?
Sure, I think in that particular injury, it's nice to break it down to the younger population, and obviously, as we were talking about the weekend warriors and our younger patients, and obviously anybody skiing or doing any sort of pivoting sport, we do see ACL injuries, which is the anterior cruciate ligament. And the reason that can be a bad one is, unfortunately, it doesn't have any healing potential, so it usually needs to be reconstructed. That's something we see relatively frequently in the office. And then something even more frequently would be, meniscus injuries, which is the shock absorber between the femur and the tibia. And that helps to provide a cushion, and that can oftentimes be torn, especially in any sort of pivoting sport, or even just from wear and tear over the course of time, and that can be extremely debilitating as well.
What are some of the common signs and symptoms for somebody with a meniscal tear?
Right. So in terms of meniscus-related pain, we oftentimes see, joint line symptoms, meaning around kind of the inside or the outside of the knee, even clicking, locking occasionally, specifically with deep flexion of the knee. That tends to put more pressure across the meniscus. So we always ask about squatting and kneeling. Oftentimes those two things in particular will cause an exacerbation of the symptoms.
How about things like locking or buckling? Will they complain of that?
Sure. Oftentimes if that meniscus fragment is flopping around in there, it can get stuck in a certain area, and that can lead to these subjective sensations of locking. So we always see that. ACL injuries, oftentimes we'll see complaints of instability, where the knee is actually giving way on itself, and that's nothing to be taken lightly, as it could lead to worsening cartilage or meniscus injuries. So definitely not something to ignore.
All right, so let's talk about that. So the first one, let's go back to the meniscal injuries. When is it typically surgical, and is there times that it can heal on its own? Is it possible?
Yes, good question. So I think, as with everything in orthopedics, we always try to take a conservative approach. First, a meniscus tear, even if complex in nature, in somebody in their 40s or 50s, in my hand, it is best initially treated with some physical therapy to work on strengthening the areas around the inflamed region in the knee, anti-inflammatories, obviously, and or a cortisone injection can all help kind of get things to go in the right direction sooner. It's an important question to ask as to, is it going to heal these things? Unfortunately, the blood supply to the meniscus, at least 2/3 of it, is extremely limited. So there's very little regenerative or healing capacity in the event that people have persistent pain despite an initial conservative course of treatment. Then at that point, considering arthroscopic surgery would be a reasonable option.
So it depends on the location of the tear.
Correct.
So if it's in that 1/3 area where there's a good supply, there's a chance that it could heal.
Those may heal.
It may heal. Okay. Yeah. So now let's go to the ACLs, and obviously that's in the news quite a bit, and it's a big injury. Professional athletes.
Sure.
What are some of the common signs and symptoms when somebody may have torn their ACL?
So what we'll often see is patients come in and say that they were, playing basketball, soccer, any sort of pivoting sport. It usually is a non-contact injury, meaning it's not, when you get clipped by a lineman, obviously it can happen, but it's oftentimes a non-contact injury where there's a pivoting moment. And in the vast majority of cases, we hear people say that they heard or felt a pop, swelling, usually delayed over the course of 3 to 4 hours. Those are two extremely sensitive signs for ACL injuries.
And then when are they always surgical, or is there times that they're not surgical?
So I think what's important to consider, obviously, is that every athlete or individual is different. Their expectations are very different. MRIs are key for making an accurate diagnosis. Partial tears of the anterior cruciate ligament do exist and oftentimes can be treated non-surgically, especially in a somewhat older population. But when people have recurrent instability episodes, we never want to leave those untreated. That could, again, lead to worsening injury to cartilage and meniscus. So definitely something that should be taken care of.
So when the injury occurs and there's some instability and they do nothing about it, what are some of the long-term effects of that?
Long-term effects of ACL insufficient knees, which I think is what we're talking about, would definitely be increased risk of some knee arthritis down the road, and instability itself can lead to meniscus injuries, worsening tears of cartilage. So again, not something we want to kind of leave alone, but down the road, arthritis is something that we can see, and obviously problems from other joints on that same leg can also be affected.
Great. I think another common thing that I see in the office, and I'm sure you do as well, is the anterior knee pain patient, either the young female or the recreational athlete. What are some of the problems that are occurring there? What are the typical diagnoses or findings?
So anterior knee pain, or basically pain right in the front, as you were alluding to, we see it commonly in my younger adolescent, especially female population, as you were saying. Oftentimes, I think it has something to do with a little bit of increased play or laxity in the patella or the kneecap itself, which can cause some irritation to the underlying cartilage, and that's definitely something that responds very well to therapy, strengthening up the VMO or the quadriceps. Oftentimes I'll put those young athletes into a patellar stabilization brace or something to give them a little bit of stability on the side of their knee. In male adolescent and athletes, we see patellar tendinitis or inflammation of the tendon, and again, that oftentimes responds very well to a course of therapy, some strapping. Both of those things can be very helpful.
So when would you consider a brace versus something else for anterior knee pain? And females more prone to this problem?
Yeah, it's definitely something that we see in terms of that demographic. I think in adolescents specifically, a lot of these girls come in. They're usually skinnier. Their legs are a little skinnier. They are growing relatively quickly. Hormonal regulation of ligaments is definitely something that people have talked about, and all those things can kind of lead to a little bit of increased laxity there. Oftentimes, we'll see other associated symptoms like elbow hyperextension. It's something else we see. So they tend to have these loose ligaments in general, and that can definitely predispose them towards that. In terms of your other question with regards to bracing, I think that's always something that we try. McConnell taping is something else that's described in the physical therapy literature. I'll always try, all of those things to try to get my patients comfortable. Rarely will need to consider something like arthroscopic surgery to do a release of some of the tissue that may be kind of binding up the kneecap there, but we always try the other things first.
Yeah, I mean, if it's a chronic instability and all conservative treatments fail, then there are surgical options for that.
There are.
Okay. How about the hip area? What are some of the common injuries that occur around the hip this time of the year?
Sure. So I think what's probably gone underdiagnosed for many years is some injuries to the labrum, which is in the hip. That's the shock absorber between the ball and the socket. Oftentimes that was just thought of as a sprain or some tendinitis. So I think it's important when you have an athlete who's complaining specifically of groin pain, usually in a C-shaped distribution, you always have to be worried about true intra-articular or in the joint type of hip pain. And the labrum is something that I feel has gone, relatively underdiagnosed for some time. So I think if people are having persistent pain in that area, extremely important to get it looked at, so at least you can have peace of mind knowing that maybe it's a little hip flexor tendinitis, or if an additional workup would be required if there was a concern for, say, a labral injury or something else inside the hip joint.
What is required to help that diagnosis? Is that an MRI or any specialized testing?
Correct. It is an MRI, and what I find to be very helpful these days is an MRI arthrogram. That's where they inject some dye into the hip, and I'll oftentimes have my musculoskeletal radiologist inject some Marcaine or lidocaine, some sort of numbing anesthetic into the hip. That gives me a little bit more diagnostic information. If the patient feels better after that, even temporarily, in my mind, it makes the point that there is truly something in the hip that perhaps I can address and fix.
Great. How about some of the tendinitises that can occur in the hip, either the hip flexor tendinitis or sometimes people complain of snapping in the hip.
Sure.
What's going on there?
Excellent question. Snapping hip really does exist. I think most people would agree that there's two forms: external, meaning outside the hip joint snapping hip, and internal snapping hip. External snapping hip tends to be from one of the fascial kind of attachments on the side of the hip that tends to snap over. And internal snapping hip is actually one of the hip tendons that can snap inside the hip joint. And there are ways to kind of diagnose both, but they definitely can be persistently painful.
Great. So, what are some of the future things that are occurring in the sports medicine area, and some of the injections and other things that you have available to help with some of these common problems?
I think what's very important these days is looking at biological treatment, what's currently on the market, and definitely has shown a lot of efficacy, specifically for, say, Achilles tendonitis or tennis elbow, would be PRP, which is where we can actually spin down people's whole blood in the office and actually get a layer of growth factors that can be injected. It's people's own growth factors. It tends to be helpful in certain conditions for kind of stimulating the reparative process and getting some of these really stubborn injuries to heal a little quicker.
Would you see that in like more of these chronic tendinitises, or sometimes you call them tendinoses, where it's thickened?
Sure. Yes, I think they absolutely can be useful in those chronic conditions where we've exhausted a lot of other treatment options.
Anything else on the horizon in this area, biologics?
I think stem cells definitely have some interesting, future prospects. It's something that's being done in the knee now, for example, ACI, or autologous chondrocyte implantation. Big word. What it means is basically taking a little biopsy of cartilage cells, growing it out in a lab, and then actually coming back at a later date and sewing that in. It's something that is done relatively commonly in the Northeast and can be extremely helpful.
Yeah, patients always ask, can't you just replace my cartilage?
Sure.
So this is the future, right?
We are making some
progress.
Advancements there.
But you can't get the whole thing yet and stick
Not
it in
the
there.
whole thing yet.
Okay. So you grow it in a dish, and then you stick it in there, and you try to get the body system.
You can sew it in with using what's called a periosteal patch, or a little patch that kind of holds things in the right area, assuming that it's, as you were referring to, a relatively smaller lesion that can be addressed with, this advanced treatment.
Yeah, I think there's a lot of confusion there. People think you can replace the whole meniscus.
Yeah.
It's mostly the cartilage, the articular cartilage layer of the bone, right? So it's that shiny part of the chicken leg, right?
That's
the
right.
shiny stuff. So people have those problems. There are some options.
There are.
Great.
Absolutely.
Well, thank you very much for joining us.
It's been a pleasure.
We appreciate it. Thank you for joining us on You and Your Health. Until next time, I'm your host, Dr. David Bertone.